Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession.
Hello, and welcome back to the Docs with Disabilities podcast. Today we are joined by Dr. Donald Egan, a psychiatry resident at the University of Texas Southwestern Medical Center in Dallas, Texas, interested in medical education, addiction psychiatry, interventional methods, and LGBTQ+ mental health. He and Dr. Meeks discuss how his road to residency has been shaped by his experiences as a gay trainee with cerebral palsy, as well as the ways in which his identities have interacted to influence how he navigated his medical training. We begin with an introduction from Dr. Egan.
Hi, my name is Donald Egan. I am a psychiatry resident at UT Southwestern Medical Center in Dallas, Texas. I am originally from Houston, Texas. I have cerebral palsy. I am a physician. I am a husband. I am a member of the LGBTQ+ community. I am a brother, son, friend, and an advocate for students with disabilities and chronic illnesses to go to medical school because I firmly believe that they make empathetic doctors and something that the medical field needs.
Thank you. I'm so glad that you are taking time out of your undoubtedly busy schedule to meet with us and to speak to our community. They're going to be so grateful, especially for this episode, because we're going to talk today about your identities and how that shapes and influences your experiences and your role as a physician. But first, I want to talk about your diagnosis and your disability. As you've described, you have CP, but one of the things we were chatting about before we started recording, and one of the things that you wanted to discuss, and I think is really important, is the idea of proving your disability. Why don't you help our audience contextualize the functional limitations that you have and why your disability may not be apparent to the average person?
Sure. So I think I have to start off with that it hasn't always been that way. I was diagnosed with CP pretty early on. I have a twin sister, and so my parents were able to compare two babies developing at the same time. And so they were able to pick up on very slight changes very early on. And I was able to receive the diagnosis early on, and my parents were very aggressive with treatment. Growing up, I went to physical therapy twice a week. I should first start off by saying that my CP affects the entire left side of my body. So my left arm, hands, leg, feet. And so for physical therapy, I did 1 day a week for my lower body, 1 day a week for my upper body. And in addition to that, I had some Botox injections into my muscles in my leg to make them looser, so walking was easier. But it wasn't a quick fix. From the ages of probably 3 or 4 up until 4th grade, I was in a brace in my leg. So my disability was very visible. And I remember being treated differently. I remember teachers sort of limiting what I could do at recess because they were afraid that I would hurt myself because they saw the brace and thought that I was fragile. And my arm at the time wasn't as defined. The muscles weren't as defined. And so it was much more spastic and held in a fixed position. So it was a lot more obvious to the world. But after years of physical therapy Botox injections. I had a tendon split surgery on my foot in the fourth grade to help position my foot differently to where I didn't have to have the brace. Then I was switched into this category of having this invisible disability. And since then, I've been straddling both worlds. My disability to me is very apparent and is something that I think about every single day with everything that I do. But fortunately, it is not something that others pick up on every single day unless I'm tasked to do something that requires a lot of dexterity with both hands or with my left hand, especially. And that's caused some awkward moments in medical school, especially because when you're tasked with doing something with both hands in medical school, there is this thought that there's one way to do it and there isn't a deviation outside of this. Whereas growing up, I was taught and I learned to always deviate and to accommodate in my own way. And so the expectation for me in medical school was to just do this the same way that everyone else does it, because looking at me at first glance is you are just like everybody else in medical school. And it has been this idea of proving a disability that I wonder if I just didn't have a left hand at all, or if I was still wearing my brace, then people would assume that I would just be doing things differently. And so I feel like that comes with its own challenges. I've been fortunate enough to talk with students who have disabilities, and a lot of them share the same sentiment of having to prove your disability when it is something that is very personal and something that you deal with on a day to day basis, but the world doesn't see it that way.
And I'm sitting here thinking as we're talking, if you have a disability that's lifelong, you're not necessarily seeing a provider on regular intervals either. I would imagine that you have a physician. I'm thinking about this burden of proof and needing to get documentation. You have a physician, but if the documentation requirements are saying, oh, we need documentation from the last 6 months to say that you have this chronic illness, and you may not have seen your physician for a few years.
It's interesting that you bring that up because I had a very similar situation to what you described in medical school. So the first 2 years of medical school went by pretty easily because a lot of it is just clinical learning. You're studying a book, and there were some struggles with anatomy lab and some clinical exercises, but overall it was pretty fine and easy to sort of fly under the radar, so to speak. However, beginning my clinical years, I told myself that I wanted to be as transparent as possible, and I did not want to go into a situation where I'm not prepared or the attendings aren't prepared, and then I'm questioned as to why I wasn't transparent and straightforward about my limitations. I met with the ADA coordinator at my medical school, and she asked flat out, I need a note from your doctor, and I need them to list everything that you can't do. And I was in this position of, well, I hadn't seen a physician for my disability in a really long time because I had spent the previous 20 years learning my own way to do things. I, at that point, knew all of the exercises and the stretches that I needed to do. And I guess I never thought about it as here are the list of things that I can't do. It was always these things may be difficult for me, but I can find a way to do them differently. And if not, I'll find another way kind of around it. So it presents this difficulty with the ADA accommodations and that sort of proving the disability because it isn't as clear cut as like, this is what you can and this is what you can't do.
It's so interesting because for me, much of my work has been touting the benefits of a qualified disability resource professional, somebody who knows and understands medical education, who is the conduit to all kinds of resources and understanding and can help the learner understand what they might need, but also protects the learner in some ways. But more and more, I'm hearing these stories of how the ADA person or the disability person was actually a barrier to access in the clinical space. And that learners have this belief that if they had just said to their attending or said to their program director or their clerkship director, look, I have this and I just might need to do it a little bit differently, but I can do it, that it would have reduced the time that they spent and invested in figuring out the accommodation. And it would have been kind of a win-win because at the end of the day, many people report that despite having gone through the right process failed. And they wound up having to go to the clinical faculty anyway and say, this is all I need to do differently. We were talking about a procedure before we started. If you were able to just say to that clerkship director or that attending, this is the way I do it because I have CP and it affects my left side, it probably would have been no big deal at the end of the day. But we have these structures in place to protect the learner. And it's become an interesting challenge for me because I want so badly for people to go through the system in a way that is structured and informed and supportive. But when those structures fail, it really is the person that you're working with that winds up being the most helpful. And in the correct structure, we're also telling faculty, don't make accommodation decisions, refer all learners back to the disability office. And so that limits and probably frightens the faculty a little bit about, well, I shouldn't be making these decisions or I shouldn't be adjusting anything. Did you ever have to go straight to one of your preceptors or faculty members to figure out a workaround?
So, finishing the story, the ADA coordinator handed me the accommodation paper and I threw it away because I knew it was going to be a waste of time. It was middle of medical school. I didn't have time to go find a doctor to write this accommodation for me. And also, that was just not how I had lived my life, period. And it wasn't going to be how I lived my life starting then. And so I did exactly what you said. I just took it day by day and would talk to the attendings if necessary. I learned very quickly that even in what you would expect very regimented fields like surgery, they'd make accommodations for people. For example, I had a friend who does not have a disability, but she could not do certain surgeries because looking at intestines and the abdominal cavity caused her to faint. So she could not do that. She just did like the anesthesia part of the clerkship, and they were okay with that. She didn't have to go to the accommodation office and get accommodations for that. And so I just did my own thing. I would get occasionally like some weird glances as to like, why were you doing that? But it also took a lot of extra practice on my part. I had to, going home, I had a station where I would use old shoelaces to practice surgical knots using predominantly my right hand, and my left hand is sort of just like a base. There were a few times I can remember where the attending or an upper level resident would ask, like, well, just do it this way. And I was like, well, I would like to do it this way. And then they say, well, this way will be a lot faster. And I did have to have an honest conversation about, well, I can't do it this way because I have this CP. And lightening it up is something I like to do so they don't feel awkward. But I said, look, if there was a way that I could have changed this, I would have changed it 23 years ago. It is what it is. I'm not sorry about it. It's my life, and I figured out a way that I can do it. It maybe looks a little different than what you're used to, but here it is. And I think that response went over well with attendings and with residents. A lot of them, they were surprised. They're like, I've never thought about somebody being in surgery or being in medical school that has CP or has a disability. But they never once were like, well, you shouldn't be in medical school. It was always a lot of interest and intrigue.
Well, that's good. And I do think there's certainly a lot of dissonance with the idea of disability and physician, right? But I think the way that you handled it with humor or normalizing it really quickly makes everyone feel comfortable.
In the following section, Dr. Egan and Dr. Meeks go on to think about the ways in which living with a disability often puts trainees in positions where they must repeatedly contextualize their behaviors and needs for others. Listen or read along as they discuss the labor of explaining one's disabilities, how these experiences may influence interactions with patients, and the reimagining of what a doctor could look like.
I hate that the person with the disability always has to take on that role and think about how to do it. But I also have had mentees in the past where we've role played and practiced what's going to happen when someone says XYZ. And they will say it, someone will say it along the way. And I think in some ways, having almost these mini scripts or planned or canned responses
Mhm.
is helpful. If you have them memorized or you have a way that you approach it, it reduces the emotional burden in that moment of having to think of what to say.
That's common practice for people with disabilities or chronic illnesses. Like, I have my canned response for if someone asks, "Why are you limping? Did you hurt your leg?" Because I don't walk with a brace anymore, but if depending on how tired I am or if I'm not really thinking about my gait, I will occasionally limp and walk with a different gait. And people will say, like, "Oh, did you hurt yourself? Like, what happened?" And I have my canned response for that, or I have my canned response for why are you holding things like that, or why is your arm like that? Why do you have those scars on your leg? And so it translates over to medical school and those situations as kind of having those canned responses.
Do you find that it does free up the emotional part of getting asked about it over and over again? Is there a point where it doesn't affect you anymore?
It depends. So if it's someone who just asks because they're genuinely curious or they're coming at it from a place of just concern or questioning, that's fine. And I just sort of gloss over it. What bothers me from time to time is if it is someone who has a little bit more malice, and I'll get pretty like sensitive about that. And I do think there is a lot of power because although we do carry the emotional sort of labor, always making sure everyone's okay, there is a lot of power in a way because ultimately I'm not uncomfortable with it because it's what I have dealt with and lived with forever. But I know, like, if I say it, and for example, if someone is being a little bit too hard or they're joking a little too much about how I walk, as soon as I'm like, well, it's because I have CP, it's automatically backtracking. Oh my gosh, I'm so sorry. I'm so sorry. And it's like now I have the control and the power of the situation.
That makes sense. Yeah, I was trying to think of a situation where I would ask you about a scar if I didn't know you really well. And then still, I think it would take a lot of time. I would think that that would be something that would unfold in the course of a normal relationship if it ever was that type of relationship where I would even have the privilege or reason for knowing. It would seem odd to me that somebody would ask.
I think it's the curse of being an open book, and I generally will be very honest and open with people, and they feel when I have shoes off or we're at a pool or a beach or something, it's come up. I
Yeah.
guess also, yeah, because maybe people just don't assume, maybe because I am happy generally and, very go lucky that they assume it isn't something kind of wrapped up in darkness or a tough time.
Being born with a disability and working with that your entire life, I do think that that brings kind of a level of innovation and just having had that experience as a patient, a level of empathy, as you mentioned in your introduction, to the field of medicine and to patient care. How do you think your experiences inform your interactions with other people? And given that you're in psychiatry and addiction medicine is what your focus is that correct?
It's an interest of mine and something I would like to pursue. I have a lot of interest, and that's one of them. And we could go into the intersection of the intersection between people with disability and substance use and the LGBTQ plus community because there's plenty to talk about there. But to answer the question is, it goes beyond just innovation. I think when you're born with a disability or you develop a disability very early on in life or even later on in life, you learn that you exist in a world that is not necessarily going to be easy or it wasn't made with you in mind, which is okay at times. It's not okay at other times. I think we've done a really good job of making things accessible for people, but with that idea of like understanding very early on that life is going to be tough if you don't work around this, if you don't find different ways to do things. And you always have to think 2 or 3 steps ahead in my day to day practice. Like, am I going to have to do something that's going to involve both of my hands or my left hand? And if it does, what do I do? How do I make this to where I can do it efficiently and effectively without it holding up the flow of clinic or flow of the day? And with that, I think it helps me connect with patients because in residency, we're in the hospital for the most part. We're seeing patients who are incredibly complex. They come from very different backgrounds that had very little support growing up. A lot of our patients have disabilities that have never really been addressed. And they do occupy this space where they're marginalized and they're a part of a space that the world is not made for them. And I think my understanding and my relation to that as someone living with a disability is I'm more able to connect with them. I'm more able to understand their struggles, not only with people with a disability or a chronic illness, but diagnosing someone for the first time with a serious mental illness. That's something that will have to be treated and managed lifelong. And we've had patients just this past week that have been diagnosed with a serious mental illness, and their family doesn't really understand what that means. So there's a lot of education that has to go to the family about what that means. The patient needs to understand what that means, and sort of this is going to be a lifelong thing. And I think seeing some of my colleagues address it is much different than how I would and how I do address it. Is my colleagues will just say, this is how it is, this is what you do, end of story, follow up in 6 to 8 weeks, versus me taking the time and saying, I know that this is going to be really tough because living with something and having something that you deal with every single day that the majority of people don't deal with is difficult. And there's going to be ups and there's going to be downs, but it doesn't mean that this is the end of your life. And it doesn't mean that you can not have a very fruitful career, social life, anything that you want to accomplish.
I'm sitting here and I'm wondering if there is a parallel to the thing that you talked about having to plan. So when I think about individuals who have chronic mental illnesses but are highly successful, we'll say a lot of people in medicine, right?
Yeah, more than you would think.
Yeah, the way to be effective and the way that they've managed their life is through routine, through planning, that if they're triggered by a certain thing or environment, they avoid it. There's just that pre-planning that goes into understanding how you're going to navigate your environment on a daily basis and making sure that it's optimal for you and for whomever you're engaging with. And I think that is probably something that you would share with your group of patients. That and everything else that you've just mentioned. I mean, I'm just sitting here and I'm thinking, gosh, I can't imagine as a patient getting a diagnosis that is grounded in mental health. First of all, it doesn't matter who you are, you understand the stigma around mental health. And then thinking that your whole life is about to change and how vulnerable you're going to be and the way that you would present the information versus the way others might would seem really reassuring to me as a patient. I could see how, as a patient, I would feel better having you be my physician than somebody who hadn't experienced hardships.
Absolutely. And that goes back to my introduction of why I think it is so important for there to be more physicians with disabilities and chronic illnesses. Whether you're in psychiatry or any other field, you have that empathy that is instilled from an early age and something that can't be taught. And it translates throughout all of medicine is this idea of, yeah, understanding that you're going to have to live with something and the rest of the world may not understand it. Every day, there may be challenges that other people don't even recognize as a challenge for you. You know, if you're going somewhere and there's a trigger or, you know, you feel that something's coming on and you need to take a step back or whatever it is, it does, I think, help to have a physician, especially when the physician is sort of the first like point of contact for that. Like you are the first person to tell them, here is your diagnosis, and you have ability and the power to make it a really good experience or really bad experience.
That kind of brings me to this idea of we have diversity, equity, inclusion, but now people are starting to talk about belonging. And I've always said this shouldn't be a numbers game. One of the things that was really disturbing to me early on in the efforts to diversify medicine was that people would talk about the numbers. Everything was a number. Well, we have 3% this, we have 4% this, we have 5%. Next year, we'll have 7%. And while metrics are great and helpful, it doesn't tell us about the experience that these learners are having in the environment. You could have 15% underrepresented individuals in your medical school class. And if they're having a horrible experience and they don't want to stay in medicine, then you're not successful. So, in what ways do you think that the sense of belonging is important, and how can we get there, especially for people who may not feel comfortable or safe kind of coming out as disabled?
So I think it's this idea of what does a doctor look like? What does a physician look like? And for a very long time, that's changed. Looking back at history, it's white men, then it's men, then men and women. And more recently, it's come to understand that it can be everybody. But I still think it's this idea of you can only be one because having more than one detracts from being a physician. One way to address this idea of belonging is to have individuals that exist and have these intersectional identities being loud and creating communities for that intersectionality. I think there's this idea that doctors still have to be infallible, like they can't have weaknesses. And that is the undertone of the disability is a weakness. Being gay is a weakness of some sort. And so you can have one weakness, like Superman. Superman has a weakness, but Superman doesn't have two weaknesses. Otherwise, he wouldn't be Superman. So having one weakness we can accept, we as society can accept. But more than that, then we're questioning, like, well, does this person even fit our idea of what a doctor or a physician is? And I think people that do exist in the intersectionality of a underrepresented group in medicine as far as race or gender and disability need to be vocal, need to use their stories to recruit other students into medical school, and need to talk to medical schools and medical institutions that we do exist. We are not inferior to other physicians. In fact, our experiences lend us the privilege of being really, really great physicians for our patients.
I think it's a strength to bring the disability identity and any identity that has been traditionally marginalized or excluded from medicine. I think it's really important. I see the strengths in that. And our research shows us that these learners are so resilient. The physicians with disabilities have been saying for years that there's something special about having gone through that experience that they're able to transmit to the patient population. That's important.
I think it's this idea of practice makes perfect. I think my own experience, like going into medical school and going into medicine, I knew that there was going to be challenges and there was going to be difficulties and barriers versus someone, I imagine, going into medical school or going into medicine without the experience of living with a disability just assumed it's going to be easy. I think going in with the idea and the mindset of this is going to be hard, but it's not something that I can't do because I've done all these other challenging things in my life sets it out. I think you kind of approach these challenges differently, and it translates into resiliency.
Yeah. It's so funny because everyone wants resilient trainees, resilient learners. I'm like, I feel like I should have this big sign that says, these are the most resilient people in the world. This is the group you need to be recruiting and retaining. And I do see, both in my work and just anecdotally, more disability pride, more community growing in medical schools. And I blame the students in a good way. Like, I think there are these student leaders across the country that are creating these spaces for people to feel welcomed and valued and appreciated and normalized, that disability is normal. And whether we want to say that these people are here or not, they're here, right? I mean, if we look at any medical school class, we can assume that between 8 and 10% of those people have a disability of some sort. I mean, we have some schools that overrepresent, and that's wonderful. But when you look at those schools, those are schools that are saying things like, we value disability. So I think what's happening in those schools are people are just being honest because there's a
Yeah.
space that's been created that's safe.
And have you found at those schools it's coming from the top down as well? Like there are attendings and people who are in the admissions committees that live with a disability or chronic illness.
Absolutely. Not only is the commitment to disability inclusion coming from the top down and bottom up from the student driven work, but they're employing people with disabilities. They're employing physicians with disabilities, not one who's then tasked and burdened with being the representative of disability, but with staff and faculty and clinicians and postdocs and fellows. And they're actually living what they're saying their mission is. Probably could only name 3 schools that, when I think about it cross-sectionally through every part of the community, that are actually doing that we know about right now. And at those 3 schools, their numbers are really high because as a learner or a trainee with a disability, you want to come into a community where, to what you said earlier, you're not having to educate everybody for the first time. You're not having to say, oh, disability is not inability. I'm not here to sue you. I'm actually here to learn. I want you to hold me accountable to everything that was just, it's just a different atmosphere when your disability is just part of the normal course of the population and community and it's valued. I think that makes a big difference.
Absolutely. I think that that's so important. It is so multifaceted because it argues for why there needs to be recruiting of physicians, these institutions, but also why there needs to be recruiting for the medical students. And even beyond that, I think targeting students in high school and in college who live with a disability and telling them, like, hey, this is a possibility for you, because so many of them have had doctors that have told them that it's not.
And I think those messages that societally we send about who, back to your question about what does a physician look like, which is interesting. That's one of my first slides that I put up in most of my talks. And in what ways has that concept just excluded so many people and forced this non representation of patient and physician? And what messages do we send then to not only high schoolers, but junior high schoolers and elementary school kids that this is not a place for you? It's a place for you to come and receive services, but it's not a place
Mhm.
for you. And I'm glad that some people don't get that message. We have several people who are coming to medicine driven by their own experiences being a patient, and that makes me happy. So somebody's doing something right. But I know that the prevailing message still is the barriers and the deficits that you will have throughout your life.
Absolutely. And, it's interesting bringing up the talks and presentations I've given. And because I'll bring up, we have to rethink what a physician is and who a physician is. And I had a student once at a university after the presentation, they said, well, I have a problem with this because in order to be a physician, you have to be able to save a life when the time comes. You're on an airplane or whatever, like you need to be able to save a life. And I thought to myself, like, okay, that's fair. That's what a lot of people think. But if you're in this situation, there's going to be people that are going to be doing that, or you can at least instruct people if you're physically not able to. But using that argument, sort of flipping it on its head, I argue, we are in a mental health crisis. And why not think of it as we are recruiting people who will become physicians and healthcare providers who, because of their empathy and their understanding, are going to be saving lives because they're going to be taking the patients, they're going to be handling these tough issues with a lot more care and dignity than someone else might not, and saving those lives versus these rare hypothetical situations where you're going to need to MacGyver your way through an emergency.
In the following section, Dr. Egan discusses the nuances of openly holding multiple marginalized identities in medicine. Follow along as he and Dr. Meeks explore the consequences of bearing and disclosing these intersecting identities, as well as the differential ways in which they might be perceived when held by a physician.
And I also think for a lot of us, we find success in whatever field we choose because we have something to prove. We have that kind of fire within us to prove ourselves because we have to work that much harder, right? Because if you fail, you're failing like for yourself and also the community. And then for a lot of us, we're the only ones of someone with a disability or chronic illness in our positions. And so if we're not the best and doing the best we can and setting a good example, then that may prevent anyone else from following in our path.
Yeah, that burden of representing an entire identity, it's strong. And we saw that in our AAMC lived experience project. So many people talked about that, saying, okay, I've been given an opportunity. I'm the first or the first of a category to go to medical school at this school. And if I fail, I'm failing for everyone. They'll never accept another student with a disability again. And that's a really big burden to carry around. But I imagine it's similar to you also identify as part of the LGBTQI family. At some point in medicine, it was also like that for our queer community, where it was like, if I'm here and I'm representing part of this community and I do something that is taken as offensive or wrong or not in keeping with medicine, I'm thinking even going back, 20 years ago, that there would have been some pressure to perform or overperform, as you're describing, as part of that identity and part of that community.
Yeah. And it also, with both, it's this idea of like coming out and sharing too much or too little of your identity with your patients and with your colleagues. I do think, though, that being a part of the LGBTQ plus community and the disabled community, at times it is a lot easier to be out as a member of the LGBTQ plus community versus the disabled community, because there has been in the past 20 or so years a big push within medical education and just medicine in general to recruit and retain physicians that are part of that community. There isn't, as far as I know, a push at all to kind of recruit and retain physicians with disabilities.
Yeah, we're trying. We're trying because disability is part of that diversity umbrella. And so one of the things that I will talk about a lot is making sure that you don't leave this population out of diversity focused efforts. So, talk to me about intersectionality, about being in medicine with these two identities. I know we talked briefly before we started recording about my research that shows across the board an overrepresentation of LGBTQ plus individuals. And I have hypothesized along with my research team, we've talked about it a lot. What does this mean? Why do we keep seeing differences in this population? With this idea that perhaps once you've come out, in a sense, with an identity that has been marginalized in the past, that places you in a community that has been stigmatized and where bias has occurred and harm has occurred, that perhaps coming out as disabled is a little bit easier because you've already hit almost like a disclosure threshold. I don't know. What are your thoughts on that? Why do you think we see those numbers?
I think what you mentioned has probably a lot to do with it. This, once you've sort of checked one box, it's a lot easier to check other boxes. I think also just from my personal experience and looking into the trends of LGBTQ plus people and how that's changed over time, the number has gone up, but I think there's still this belief, there's still a lot of stigma. We talked earlier about how there's still a lot of people and they have these outdated beliefs, and it's still very difficult for some people to come out. So I think that we still aren't seeing an accurate number of how many people identify as LGBTQ plus in the United States. I think though, when you grow up with a disability and you see the world differently, you see yourself differently, and you realize from an early age that these rules don't apply to me, I think that offers people the freedom to be true to themselves and to accept the fact that they identify within this community.
Yeah. So in some ways, even though these identities have risk that go along with them and in taking on the identity, that there's some beauty in it too, where you get to live very authentically and you make a decision at some point that you are going to be this authentic version of yourself and hold these identities regardless of what other people may attribute to them or feel about them or have biases against them.
Yeah, exactly. It's this idea of when you live outside of standard society, when you are marginalized, it's sort of like all the rules can apply or cannot apply if you want them to. There's a lot more freedom with it.
And I'm wondering if there's anything that you can think of in your training and your education that has been a unique barrier for you because of these two identities and how they come together.
I think not so much just pertaining to medicine, but just in life in general, when you do have an intersectional identity, there is this idea of, well, I have to be one or the other at one time. And in medicine, maybe because there is, like we talked about, more of an acceptance and push for more LGBTQ plus physicians, it's a lot easier to be that and to be the gay physician versus the gay and disabled physician. Unique challenges, I think, comes with sometimes, even though there is a lot of understanding and acceptance for the LGBTQ plus community, there's still a lot that needs to go on. And so having both, then there's maybe too much educating that needs to go on, almost to a point like maybe it's distracting because you're having to address the like misconceptions of LGBTQ plus community. Then you're also having to address all these misconceptions with the disabled and chronic illness community, that it is just a lot to bear.
As the conversation comes to a close, Dr. Egan shares his advice for disabled trainees in medicine and healthcare. Listen or read along as he encourages students to build community and to bring the challenges disabled trainees continue to face to the attention of others in medicine.
Firstly, to the medical students, to pre-med students, to high schoolers, middle schoolers, don't let anyone tell you what you can and can't do. You know what you can and can't do. And as we've discussed during this episode, your experiences, the good and the bad, are so valuable to being a good doctor and a good healthcare provider. I think to medical students and residents who have a disability, first and foremost, congratulations for making it this far. Don't even know you, but I'm incredibly proud of you. And I want our numbers to grow. And I think how we do that is by building community. And I think with my experience starting in medical school and being the only person with a disability, I hate the thought of someone else having that. And so I think starting groups on campus, starting organizations on campus, and if that's too much, just sharing your story, reaching out to your undergraduate schools, reaching out to your high schools. It's difficult. It's something that I think a lot of us don't want to talk about. We're taught from an early age not to talk about it very much, but it's so important to share that story because if it touches one or two people, that's making a difference in one or two people's lives. And if they become future physicians, think of all the patients that they're going to touch as well. So I think that's my takeaway, something that I've had to grapple with and come to terms with later on in life that I wish I didn't, but being open and creating communities as best you can so that we can raise each other up so that we change the idea of what a physician is and who is fit for medical school.
I appreciate that. I couldn't agree more. And for the students listening, there's a group called MSDCI. I don't know if you're familiar with it. It originated in Stanford, but now they have groups at medical schools throughout the country. And so I'd encourage you to get in touch with them if you're looking to build something at your medical school. And I think that's really, really good advice is to grow a family, to grow a community so that you don't feel alone and so that we can help one another.
If I can add one more
Yeah.
thing, it's a very funny experience that I've had. So in residency, there is a resident the year below me who has a disability, a fairly obvious one. And it's been such a great experience to get to know her and to share in our triumphs and our barriers or challenges. But we met with my program director recently, and we started a group at Southwestern for physicians and residents with disabilities and chronic illnesses. And our program director is our faculty sponsor. And we were talking to him, and one of the things that we want to address is the technical standards at Southwestern. That is a very big barrier for people going into medical school. And we were talking about it with the program director. And afterwards, he said, "You know what? I've been on the admissions committee at Southwestern for 10 years, and I have never seen this. I have never thought about it. We have never talked about it." So for me, I'm like, it's not something that's addressed, but it's this barrier that is in place that I don't know how it's there. It's this antiquated system that is there. And clearly, they're not thinking about it. The people who are reading the applications are not thinking about it, but the students are because that's who's going to be looking out for it. And so, what I wanted to share is that there's a disconnect that needs to be addressed too.
Absolutely. And I'm really proud of like we have our partners, they're really working to educate their member schools. We have a webinar that we did in partnership with the AAMC, I think it was February of 2020, but it's available on the AAMC website. It's a webinar on technical standards. So it's available to anybody and it talks about how to modernize these and what the origin of them is and why there are some problematic elements and how to change those. And it really helps situate it. And then we're working currently on an anti ableist admissions module to train people about the benefits of individuals with disabilities coming into medicine and how to evaluate an applicant that has a disability, which involves a lot of just not introducing a lot of bias into that process or assumptions. But I think we're going to see a growing number of learners and applicants that are disclosing disability as part of their personal statement. I know we're seeing it. I'm on the admissions committee at Michigan and I see it all the time. And so just making sure that people know what to do with it when it enters the room. I fear the
Hmm.
conversations that might be happening, and they're probably overreaching to choose a way to sum it up. And so I just want to make sure that we have a way to address the same types of biases that we probably had 20 years ago with different populations.
Exactly.
Good things coming. And with people like you being part of the generation of learners and trainees that are committed to this work, once you're done with residency and you go into your first position, this is something you will carry with you into that work as well. And so, as much as we can support you, you're supporting, it's a constant feedback loop of people with disabilities informing my work. I get to then use that information, disseminate it, support trainees as they're coming up, trainees supporting other trainees through these programs. It's a beautiful thing. And I think everybody's paying it forward in the most amazing way. When I think back to the first time we did an analysis of the numbers and where we were even 10 years ago, I'm just amazed at where we are today. And the fact that this podcast is a thing, even, right? That there's a group that wants these stories, that is amazing to me and humbling and wonderful every day. But it is a thriving, growing community.
And I'll take this moment to thank you, Dr. Meeks, and your co-host. This was not something that I was aware of when I was applying to medical school, if it even existed. And I think about the questioning and the doubt that I had to kind of wade through in order to get to the point that I am at now. And I'm just so fortunate to play a very, very small role in this initiative and all the work that you guys are doing for students like myself and like others to uplift them.
To your point about if you can impact one or two people, the average podcast episode is listened to by thousands of people. So you will definitely be impacting thousands of people. And I know that there will be somebody somewhere with CP who thinks, I never thought I could go to medical school. That would never have even been in my realm of possibility. And now I've listened to Dr. Egan and I'm just amazed. And this is going to be my new trajectory and getting it early enough so that they can do the pre-med courses if they want to.
Yeah.
And certainly I hope that there's lots of faculty listening and appreciating the stories about how this experience impacts patient care, because it really is so important. But thank you. And thank you for your contribution to the series.
It's been my pleasure. Thank you so much.
Dr. Egan, thank you so much for taking the time to share the experiences and insights you have gained on your medical training journey, and for your words of encouragement to the students and trainees to follow in your steps. To our audience, thank you so much for joining us. If you enjoyed this discussion, be sure to subscribe to our podcast, check out our previous interviews, and tune in again next time. This podcast is a production of the Docs with Disabilities Initiative and is supported, in part, by the University of Michigan Medical School's Department of Family Medicine and Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution Non-Commercial Non-Derivative License. This episode was produced by Lisa Meeks, Sophia Schlossman, and Nicole Kim, with support from our audio editor, Jacob Feeman.